All right, guys, so today we're going to go ahead and talk about a sensitive topic, which is suicide. We're going to be talking about assessing for suicide, as well as how are we keeping people safe. If any of this is triggering to you, then just you still have to listen, but maybe listen in small chunks, or uh, utilize coping skills. And again, if you feel like you're unsafe, calling 988 or texting 988 is a really good resource to help you. Okay, and that's also a good resource for patients as well. Okay, so when we were talking about suicide, we're going to kind of scroll through this a little bit, but many patients that have depressive disorders or bipolar disorders will experience or can experience suicidal thoughts, and they can also have suicidal behaviors. When we're talking about what suicide is, according to the National Institute of Mental Health, suicide is defined as death caused by self directed injurious behavior with the intent to die as a result of the behavior. And so, clients who are profoundly depressed also maybe under the influence or very, very manic, may express an interest in stopping all the emotional turmoil that they're feeling through self harm. Okay, we're talking about what a suicide attempt is. This is a non fatal, non directed, potentially injurious behavior with the intent to die as a result of the behavior. Okay, so if someone's taking a whole lot of pills, a patient, has a gun and is trying to harm themselves with a gun, um, pushing themselves in the middle of traffic, jumping off high buildings. This is all suicide attempts. Okay, if someone has had an attempt, they have not, you know they haven't died. Okay, but this is something that they did do with the intent to die. And sometimes a suicide attempt might not result in injury. And then what is suicidal ideation? Suicidal ideation refers to thinking about, considering, or planning suicide. Um, it is very important to understand that the use of terminology behind death by suicide should not be referred to as a successful suicide. Patients that have died by suicide, we need to make sure that we're being very sensitive and saying, somebody died by suicide or somebody attempted suicide. Somebody having committed suicide or attempted suicide is just not the best lingo for it. When we're talking about suicide for young clients 10 to 34, suicide is the second leading cause of death, and the highest rates were amongst indigenous people, non-Hispanic, white, veteran people in rural areas, and people who work in industries like mining and construction. Young people identifying as lesbian, gay, or bisexual were more likely to have suicide ideas and behaviors than their peers who identify as straight. And then global firing arms, hanging, and the use of pesticides are the most common means by suicide. Okay. Um, Clients who are experiencing depression may think about suicide as a measure of symptom relief. It's important for the nurse to assess the client's risk for suicide when the client is admitted into care. Okay. And then if somebody is admitted into care due to suicidal ideations or suicide attempts, then the patient needs to be continuously monitored. Okay. And so let's go ahead and look at a couple of things that we need to ask about when we're doing a suicide assessment. So you can use the mnemonic MILK. So M means. How does a person have the access to enact the plan? So somebody, if you're doing an interview on a patient in the inpatient or outpatient setting that has suicidal ideations, maybe they are starting to have a plan. Well, how does the person have access? Do they have guns in their house? Do they have access to medications? Do they have access to other things that can, allow them to die by suicide? Intent. Do they have a plan? Some people just have thoughts, but they don't ever have any plan. lethality. How deadly is their plan? If they say, I want to shoot myself in the head, that's going to be a pretty deadly plan. But if they want to, take 2 ibuprofen, it's not going to be a very lethal plan. Okay. And then cues and behaviors, covert and overt, verbal and nonverbal cues that are going to, bring about the thought that somebody wants to harm themselves. Sorry, I'm trying to look for like the right word. So when we are looking at assessments, the Columbia Suicide Severity Screening, it says it can be found in this lesson, and I don't know where it is, but as we go through this, oh, here it is. So we're looking at the Columbia Suicide Severity Rating Scale. Typically, this is done at many hospitals, but this right here is going to, this a lot of times is in Epic or Meditech. And this is going to be charted. And so, has the person ever had an actual suicide attempt, interrupted, aborted, other preparatory acts to kill self, suicidal ideation, so wish to be dead, suicidal thoughts, activating events, treatment, has anybody ever been, hospitalized, so on and so forth. So please make sure that you look at this, because and this has, this is a decently long document, but please make sure that you just review it, and we'll review it in class a little bit. But this is, if you are in clinical, you can ask to go into Epic to see if you can see this. And then there's another assessment called a safety assessment. This is also in the Engage, but I really like this little pamphlet. But it essentially categorizes that based on the patient's questions and the things that are going on, puts them at a high, moderate, or low risk for suicide. And so risk factors is the first thing that we're going to do. Identify risk factors. So any prior suicide attempts, alcohol, substance, any mental health concerns, access to lethal means, including firearms, so on and so forth. Populations that are increased risk. We literally just talked about this, but Indigenous people, Alaska Natives, Black youth, rural communities, LGBTQI plus communities, youth and young adults, middle-aged men, and then older adults. We talk about protective factors. Protective factors are factors that that are going to prevent somebody from wanting to end their own life. So it's supportive environment, if they have effective behavioral health care, life skills like emotional regulation and good problem solving skills, high self-esteem, cultural beliefs that discourage suicide, and no access to lethal means. Then we're going to ask them a little bit about their suicide inquiry. So ideation, how frequent, how intense, the duration, in the last 48 hours, the past month. Do they have a plan? Behaviors, past attempts, aborted attempts, and then the intent. Expect to carry out the plan and believe that the plan is going to be lethal, okay? And then explore ambivalence, or reasons to die versus reasons to live, okay? And then based on all of that, we can go ahead and do an assessment and, have them as a low, moderate, or high risk for suicidality. Typically for a high risk or moderate risk, these people are going to need to be hospitalized. Low risk is not going to need to be hospitalized, but we need to make sure that the patient does have a safety plan, and giving them the 988 number is also going to be helpful. If you don't know the 988 number, you can call them or text, and they will respond to text. Okay. So we're going to go back up. So those are some of our assessments. if we scroll down, we can look at some risk factors and warning signs for suicide. You will need to know this for exam purposes. But risk factors include, like we just talked about literally just a few seconds ago, mental health disorders, depression, but other things, chronic pain, previous suicide attempts, veterans, firearms in the home, recently released from jail, exposure to violence or trauma, so on and so forth. And then warning signs, okay? So these are some signs that if you start seeing somebody do some of these things, this should, or your patient is talking about some of these things, this should really raise a red flag. So stating that they want to kill or die or kill themselves is obviously, no brainer, but stating that they feel hopeless, no reasons to live, they're starting to feel trapped, feel like a burden to others, withdrawing socially, giving away loved possessions, bidding goodbye to friends and family, arranging affairs, engaging in risky behavior like driving fast and obsessing and thinking and talking about death are all big ones. And somebody had called me a while back ago, and they were feeling frightened because their spouse has chronic pain, and the spouse had said to the person that had called me, the spouse had said, I know, I can understand why my aunt killed herself, because this pain is so bad. And so the person that called me was kind of just like, oh my God, I don't know what to do. As if this person was calling, and the nurse, and you were the nurse on call, how would you respond to this? So you would want to ask a couple of things. You'd want to say, well, are they wanting to kill themselves? Are they feeling hopeless? Are they starting to feel withdrawn? Have they made a statement that they do want to die? Or are they having empathy for somebody else, seeing as that though they're exhibiting some similar symptoms, and it's really tough to deal with. So you'd want to, delve a little bit more into those, and then give resources, right? Call 988. Give that resource to the person. Tell the person, hey, if they start to say other things or start to feel withdrawn or start giving away their assets or talking about their, affairs, these would be signs that, you'd want to get the person a little bit more higher level of help. And then other warning signs: sudden extreme mood swings, suicide plan, complaining about feeling great shades of guilt or shame, more just risky behaviors, displaying rage or talking about seeking revenge. The nurse should plan to address their client's suicidal ideations by least restrictive means first. Speak with the client and develop a plan for safety. A plan for safety may include a people to contact, coping skills, or places to go if a client is experiencing increased suicidal ideations or self-harm plans. The nurse should utilize the milieu to promote safety. This includes frequent observations, removing items that could be potentially dangerous, considering the proximity of the client's room to the nurse's station. In the cases of breaking through anxiety, the nurse should consult with the healthcare provider and client to discuss the potential use of medications to relieve symptoms. Okay, and so I know that was a lot, so I'm sorry. Again, utilizing this right here, the safety assessment, the 5 evaluation. This is this right here. Okay, this is just an acute fund document. ATI also has it. Oops, right here. It's literally the exact same thing. Okay. All right, mnemonics, because mnemonics are awesome. Sad persons is a great mnemonic to help you understand determining suicide risks. Okay, and I have it right here. If you wanna, it won't get small. Let me see if I can make this bigger. There we go. So if you wanted to take a picture of this, you could. But when we talk about risks for suicide, sex, male, age less than 19 or greater than 45, the patient has a history of depression, previous suicide attempts, excessive alcohol or substance use, rational thinking loss, separated or single, organized plan, no social support, and sickness. Okay? And so those are risk factors. And we're talking about, I really like some of this right here, but the S stands for male sex. The statistics show that genetic males are 3 times more likely to die by suicide than genetic females. Younger than 19 and older than 49, young people face specific risk factors that elevate their suicide risk, including higher rates of bullying, social media pressures, feeling isolated, and impulsive decision making. On the other hand, older adults experience risk factors like extreme loneliness and lack of support, declining in health, loss of independence, burdening others, feeling worthlessness, and this is how they and a lot of times older folks have a easier access to lethal means, which increases their likelihood to die by suicide. D stands for depression. Approximately 90% of people who die by suicide have a mental health disorder. P stands for previous attempt. A prior self-harming suicide attempt increases the risk by dying by suicide in the future. E stands for excessive alcohol. Many people turn to alcohol or substances to cope with feelings of depression and anxiety, creating a vicious cycle of worsening mental health. R stands for rational thinking loss, which means the patient has a distorted sense of reality. This can happen especially with psychotic disorders like schizophrenia, and like we did talk about when we talked about mania, patients may have psychotic features as related to mania, and this can cause delusions and hallucinations. We talk about S, separated or single. This is the absence of close and intimate relationships. It's a significant risk factor for depression. And again, this profound feeling of loneliness. O stands for organized plan, which refers to having a specific plan to end one's life. N stands for no support. Again, this is the lack of meaning for relationships, which can increase guilt, hopelessness, worthlessness, and the lack of like a supportive environment. And then S stands for sickness, which refers to chronic disease like end-stage cancer, which can be very difficult for people, as well as I think people with dialysis tend to kind of get lost in the shuffle. But patients that have dialysis, dialysis can be really, really tough on somebody, especially because I don't know a whole ton about outpatient dialysis, but I think it can take like 5 to 6 hours for patients to go through dialysis. A lot of times if someone's on dialysis for 3 times a day, after dialysis they get really, really tired. It can be really lonely. They can't do certain things that they want to do, and lots of people with dialysis that I have encountered, not evidence, but that I have encountered, become very, very frustrated with just their life as it is, and their whole life is around dialysis. And so a lot of these patients become very, their distorted thinking starts to peak. Okay, so this is also, other risk factors for suicide, so you can go ahead and read that on your own as well. And when we're talking about, again, nursing, what is nursing doing? Nurses need to be especially alert to signs of clients that have developed a suicide plan or are about to act on one. On inpatient units, it's the nurse's responsibility to remove any sharp objects, potential weapons, or items that can be used to complete suicide. And then if somebody is getting monitored, like on suicide precautions, they're to be monitored, continuous monitoring by staff at least every 15 minutes during the day. But I think in the real world, they're just constantly monitored 24/7. They're documented on about every 15 minutes to every hour. Okay, so this is clinical presentation of suicide. So again, this is kind of talking about the exact same thing that we just talked about, but clients who are depressed considered suicide to resolve physical pain or emotional turmoil. And then, make sure we are focusing, or make sure you are understanding concerning cues and behaviors for patients that are suicidal. Using the suicide risk assessment, such as the Columbia Suicide Severity Scale, or CSSRS, or the safety assessment, to determine the risk for suicide, evaluate the severity, and determine the client's needs, is also, important. And then again, I think we've talked about this already. The role of the nurse, responsibility. Remember, safety is our highest responsibility. And yeah, ATI says that suicide precautions, nurses must do suicide assessments. This may include talking with the patient randomly, but at least every 15 minutes if the nurse comes into contact. So remember, nursing must have assessment for suicide every 15 minutes per ATI. And remember, that's different than in the hospital setting, because in the hospital setting, if someone's on suicide precautions, they're being constantly looked at. Okay, well, that is about it. Go ahead and review the nursing process as it relates to suicide. I think this is all kind of just starting to repeat itself, and I don't want to sit here and repeat things that I've already talked about. So make sure that you're understanding for suicide, the safety, and more safety is the biggest thing. Okay? All right, that's it. Happy studying.